The third characteristic of primary care is that it's built on a relationship that extends over time, that it's continuous, that it's over longitudinal, not limited to a particular episode of care, not like an emergency room doctor where you see the patients when they come in. You establish a relationship with the patient and with their whole family that is there for as long as the both of you are around. I'm a family practice doctor, and so we say we deliver medicine to families. You know, it's the womb to tomb area, whereas other specialties may do for children and adolescents or for adult medicine. The last section, last part of the hallmarks or the pillars of primary care is care coordination. It means that when you need to see a specialist or you have discharged from the hospital and you need home health care, it's the family doctor or the primary care doctor that makes those arrangements. If there's medicines that are prescribed by different doctors, it's the primary care doctor that reconciles that list and brings it back into a safe area. Dr. Barbara Starfield was a champion of primary care. She spent her whole life researching it and promoting it, and she summarized primary care in one fairly long sentence, but I still think the sentence is useful for us. It's the provision of first contact, person-focused, ongoing care over time that meets the health-related needs of people, referring only those too uncommon to maintain competence, and coordinates care when people receive services at other levels. Who are the providers of primary care? Well, the primary care specialties are the three specialties of family medicine, general internal medicine, and pediatrics. The internal medicine will see patients who are adults and provide the primary care services. Pediatricians, the children, adolescents, and even the infants. Now, other specialties, other doctors provide primary care services, and I think particularly of OBGYNs who deliver a lot of primary women's health care, but they are not considered a primary care specialty, and reimbursements are not based on that. And in general, the other specialties don't deliver the full complement of primary care that we talked about. There's other allied health professionals, nurse practitioners, physician's assistants, and others who also deliver primary care services, usually within the context of a team or under the auspices of a protocol that's written by the primary care doctor. So the primary care services are provided by a range of different people, but when we talk about primary care physicians, we primarily talk about these three specialties. Let's just stop for a minute and discuss why we think primary care is important. The evidence from international studies, from national, regional, even clinical trials have all demonstrated fairly indisputably that when primary care is strong, there is a decrease in mortality, a decrease in morbidity. There's fewer medications that are prescribed. There's less cost, less per capita expenditures. Patients are more satisfied. They're not running around seeing a lot of different doctors. And in terms of equity, there's a better distribution of the available healthcare resources. So primary care has a value that extends pretty much down the list. And just one example, one study that looked at life expectancy and correlation with primary care physicians showed that for every additional primary care physician per 100,000 people in that population, life expectancy increased about 1.5%, 1.5 years. And they're actually pretty linear correlation. I mean, it's a little bit scattered, but if you look at international comparisons, it's even more dramatic. But given all that, primary care still is in a difficult situation today. The United States really has not made a sufficient investment in primary care. Rather, we're spending somewhere around $2.7 trillion a year in healthcare, about 18% of our GDP. And yet we rank around 34th in terms of life expectancy. I think infant mortality is around 39th. None of our health indicators are at the top of the rank, and yet our expenditures are sometimes 2 and 3 times that of any other, even developed country. So it's an issue that results from a system that emphasizes procedures, emphasizes a specialty dominated, emphasizes competition, so that there is no incentive to rein in costs. And frankly, if there's only payment for procedures and payment for doing things, there's not really any incentive to get a high quality product. It's basically just do that test one more time, or do that intervention. So as a result of all that, primary care is in a difficult situation, but it reflects, I think, the situation of healthcare as a whole, and perhaps even our society. And the causes for the problem are really, I think, supply and demand. We have a lot of demand and we don't have much supply. And as a consequence, we have these lower health outcomes and general dissatisfaction with the way things are. Looking at just the demand side of things, we see that over the next 10 years or so, the adult population is going to continue to grow. But the gap between that and the primary care providers is going to widen. We're not going to make it at this current rate. And I don't have a solution for this. I don't think we're ever going to get back to the point where there's going to be a primary care doctor for a reasonable number of patients. So the solutions to some of these problems that we'll talk about are different from just, part of it is having more doctors, but part of it is thinking smarter about how we deliver the care. Not only is the population, our demographics in our country aging as we grow older, because of the wonders of medicine, people are living with chronic conditions for a longer time. And people don't die of infections like they used to. Tuberculosis, HIV, you name it, pneumonia used to be the captain of death. But now people recover. There's better treatments for heart disease, there's better treatment for cancer. So there's many more people who live with chronic conditions. As a matter of fact, almost 50% of the senior citizens now have 3 or more chronic conditions. And all of those conditions require ongoing medical care. And most of it can be delivered in a primary care setting. So that's the demand side. And that demand side is projected to continue. On the supply side, we see a real problem. This is Bureau of Labor Statistics data for the last decade. And you can see the red line is the population growth, and the green line is the supply of primary care doctors. So it bottomed out in about 2008, I think, 2009. It's beginning to tick up again, but like I said, I don't think we can get back to that, certainly not in a fairly short period of time without a radical, dramatic change in the way our system is structured. So like I say, that we need to look at other solutions to that problem. But the gap and the gap between supply and demand is one of the crises that we have in healthcare today. The next thing that concern that we have about primary care is the actual doing of it. The workplace environment for primary care can be a hectic, chaotic place. There is a lot of demands on the attention of a doctor to see patients. So I'll talk about that, and then I'll also want to talk a little bit about the supply line deficits, because that's the third element, and it's related to the first two. So the income disparity is stark. Family medicine and internal medicine and pediatrics rank at the bottom of physician specialty compensation. And if you compare it to the highest compensated specialty, which at least in 2011 was radiology, there's a gap of more than double. And over a lifetime, a career, that can add up to $1 million or more dollars. So I think that one of the problems that we have in attracting primary care physicians is that the amount of student loan and debt that they have through their training and the residency program is considerable. And they look for ways in which they can get out from underneath that debt in the easiest time possible. So I don't blame them for choosing specialties that will compensate them at a higher level. I really blame the system for not valuing the kind of work that's necessary to be able to produce good health. Now, there are efforts already underway to address some of this, and I think that those efforts will accelerate in the future. So I think that the disparity in income will narrow over time. But as long as we have a system where procedures are, there's payment for procedures rather than for the cognitive work that's really being done to take care of patients, we're going to have a gap like this. So that should change. And the environment, like I said, it can be a hectic, chaotic place. If you think about the traditional model of primary care, there's one doctor and his staff, front office and back office. And he basically, or she, has the responsibility for everything. Patients see that. They think their doctor is the answer. But now, in our system, with what we have in medicine today, average patient size is about 2,000 to 2,500 patients. And if you were to deliver all of the chronic care, all of the acute care, and all of the preventive care that all of those patients need on a daily basis, it would take about 18 or 19 hours out of the day. And you still haven't answered your phone calls or done your administration or some documentation that's necessary. And then you want to go home at night and have a life. So clearly it's not possible. And it isn't, but it leads to frustration on the doctor's part because they feel like they should be doing more. And it affects the quality of the healthcare because some things get dropped off that can't be done. And like I said, there's a supply line problem as well. There are some efforts to increase primary care residency training, but over the next 5 years, that's going to put out only less than 1,000. And the American Association of Medical Colleges projects that we're going to need about almost 30,000 by 2015. And they say that that could even double before 2025. So we're doing something, but we're certainly not doing enough to be able to provide sufficient amounts of primary care doctors. And don't look for nurse practitioners and physicians assistants to fill that gap. They're producing also, their programs are producing people, but not nearly at the rate or the level that would be necessary. And clearly, they're going to have a bigger role to play in primary care. Looking at the residency for this year, there were 26,000 PGY1 positions that were offered, a little bit more, which is the most amount that have ever been offered. And it includes about, I think about 1,000 internal medicine positions, about 140 new family practice residencies, and 100 or so pediatric residencies. So there are more primary care residencies, but it's still about 45% of the PGY1 positions that are offered. And my personal opinion is it should be around 80% or 75 to 80% if we're really going to get serious about addressing the problems with primary care. Most of them filled, about almost 99% filled. And U.S. graduates, seniors from U.S. medical schools filled at a rate of about 93 or 94%. And U.S. citizens from international medical schools filled at a better than 50% rate. And for non-U.S. citizens from international medical schools filled slightly less than that. And we have and the other thing I'll say about the internal medicine categorical program is that studies that have looked at their track record after they finish these residencies show that half, or maybe even more than half, wind up specializing in one of the subspecialties of internal medicine after they finish their categorical program. So the number of actively practicing primary care doctors is going to be less than what we see here in training. Okay, so I painted a picture for you that looks pretty grim, but don't lose hope. And within every crisis, there are the seeds of opportunity. And some of these things are already well established and moving forward. Some of them are, I think, coming. The first one is the patient-centered medical home. Have people heard of that before? Have anybody heard of the patient-centered medical home? A few people have, okay. This is a collaborative effort that was started a while ago by the primary care specialties, American College of Physicians, AAFP Family Practice, and Pediatrics. It's been adopted by insurance companies and is an integral part of the Affordable Care Act. And it's a redesign of primary care. It contains the 4 pillars that we talked about earlier, but it updates it to include a team approach that does away with the idea that the primary care doctor is the interface, the only interface between the doctor and the patient. It includes quality measurement and improvement efforts as an integral part of the practice, links to community neighborhoods. Health information technology is really important, and it establishes, it's moving towards a system where we're looking at population health. We're looking really at the outcomes of healthcare. What are the determinants of disease, or what are the determinants of health within the community that is served by that primary care center? To be a patient-centered medical home is a certification process, a 3-step certification process. And so it's a fairly rigorous system, but many groups and clinics, some of them are already in existence, and some of them are really showpieces for what can be done. Very innovative and attractive ways to deliver care. And other people, like I work with Communicare at the Davis Community Clinic here. We're getting started making our application and doing the population surveys and beginning to reorient our team. Health information technology is going to be a big part of all future medical care. And I think about 50% of primary care physicians now are using the electronic medical record, and that percentage will grow. And there will be better integration. Right now, some of these systems are proprietary and they don't merge very well with the data. So you're hampered. But within one of these medical homes, the information is interchangeable, so that specialty reports from specialists and hospitals are available to everybody within the team, within the medical home. So it achieves the triple aim, which is, and this has been demonstrated by the projects that are already in existence. It shows that we can improve the experience of care, improve the health of populations, and lower the cost of care. I just give you one example. I used it in the previous talk. I can't remember how many times we have a patient, say, with a back injury or a bad back or a knee, and we'll order an MRI and find some problem that needs orthopedic attention. Just call up the orthopedist and refer them. And sometimes the first thing they say is, I want to do my own MRI. I want to repeat that test. And there's a duplication. Maybe they don't have the test that was done, or maybe they want it done just to review it from themselves. But that's part of the duplication in medicine that we can eliminate by having a better integration of records. So the way it works is that we used to say that when you come into the office, you are faced with the tyranny of the 15-minute visit, where you see, your schedule, and every 15 minutes in the morning and every 15 minutes in the afternoon, you've got a patient scheduled. And you look at those names and you know that there is no way that Mrs. Jones is going to take 15 minutes. She's going to take a half an hour. Or you've got a procedure that's going to take longer, or you've got an emergency or a walk-in. And yet you still have these patients who are out there waiting to come in. It's a really difficult situation. We think that 35 to 40%, maybe more, 50% of chronic care follow-up visits really don't need a face-to-face encounter with the primary care physician. That can be managed by a care coordinator, by a nurse practitioner, by maybe a behavioralist or a dietitian. So we stratify the patient according to what their need is, and we try to assign the provider who can work at the top of their skill level to take care of that problem. So no longer do you have to go through things that someone else could do more efficiently and perhaps even better. I mean, a dietitian can probably give better information on nutrition than maybe a physician can. That's her job, that's her specialty, that's her interest. So stratifying the patient means that the doctor doesn't have a 15-minute schedule throughout the day. He's working on protocols. He's seeing the patients who are most difficult and need to be seen, but he's also working maybe with the community. He's working on protocols for prevention. I keep saying he, but it's probably going to be the majority of she's out there doing this as well. So I think in the not so distant future, you can look at a system where patients go online and book their own appointments when they want to come in. That we see 1/3 of our visits through video conferencing or texting or email, that they don't need a face-to-face encounter. That patients can have access to their medical records, all of it. Or they can come in. I like the idea of creating a waiting room that looks more like a community center where people can drop in even without an appointment, learn a little bit about healthcare, search the net for information about their disease, maybe meet with a health coach, maybe have a group meeting, so that it's not the dreaded doctor's office anymore. It becomes a vital part of the community. It's a place where people want to go to because they find some value in going there. I'm going to kind of skip through this really quickly, but there are a lot of reimbursement changes, and reimbursement changes are necessary to make effective changes, as you know. Accountable care organizations bundle payments among an association of hospitals and providers and other ancillary services, so there's less incentive to continue just to do more. You spread that out. If there's a rehospitalization or a complication, that's included in the bundle, so there's no extra. Prospective payments, global service payments are prospectively given to an association to keep the population healthy. And then there really will be opportunities to get reimbursement for virtual visits, so that some of the emails and video conferencing can be reimbursed. And that'll all help. The Affordable Care Act will have a big impact on primary care. First of all, we know that there will be as many as 32 million people who will have access to health insurance, and studies show that when people have health insurance, they use it. I think that there's about 7 million of that 32 that live in California. So if you're California-based, we can expect to see an increase in the demand for primary care just from that population. There's new models for payment, like we talked about, the primary care medical home. And there is components of the Affordable Care Act that provide more focused training on primary care. I don't think that that is going to get us all the way home, but it's a good help. And I think I didn't get to talk to any of the deans of the medical schools here that are here for this conference, but from just looking at some articles and listening to people talk, there is a serious discussion about reforming the curriculum, because primary care curriculum as it is now is pretty much, you go to orthopedics for 1 month, then you go to pediatrics for 1 month, and then you go to cardiology for 1 month, and then maybe you go to ophthalmology, and then you got an elective, you can do derm, and that's it. So you're basically plopped down in these different specialties. It's not a cohesive training program, and it doesn't really gear you towards the kind of practice that we think we're going to be encountering in the future. So I think medical schools will change that. I also think that the academic medical center is probably going to have to look at some changes, because they are some of the highest cost of users of medical technology in healthcare. And if we're really going to be focusing on primary care, maybe they don't need to spend so much time in those academic medical centers. So these are things that are sort of on the horizon. They haven't really happened yet, but people are talking about it. I mean, people who can make those changes are talking about them, and that's a good thing. So we've talked a lot about where changing the office, the doctor's office, the primary care office, but I think today's society is going to demand more access points into the healthcare system. Already we see that there are drop-in clinics located in the pharmacies and the big box stores. There are retail clinics that are opening up that can provide limited primary care services. I counted just the other day 5 companies that provide a doctor online. You swipe your credit card and the doctor pops up on your computer screen. You explain your problem and she looks down your throat and writes you a prescription. So, it's patient convenience, it's patient's demand. Why, if you don't need to take time off from work, you don't have to take your kid out of school, you can utilize some of these services. We may not like it. It really kind of rubs us against the wrong way. Like, there's even an emergency urgent care internet service now. And like somebody was joking, like, well, how do you stop the bleeding through the internet? I don't know. But, for some people it's going to work. And I think that consumers are going to use those services. And I think that that's going to put even more pressure on primary care to change the way that they do business or see patients and make it more of a consumer-oriented experience for them. So this diversity is really going to happen. And I really do think that the diversity in our society, both occupationally and structurally, will propel a lot of the changes in healthcare. We just look at the younger people that are going into healthcare today, into medicine, are looking for a better balance between their work and their life. It's not where you are married to your career as it used to be. There's less call, and there's probably going to be less hours. And that also means there's going to be more flexibility and more innovative ways in which healthcare can be delivered, and primary care can be part of all of that. So, there are many factors that go into, many people choose the specialty that they go into for a variety of reasons. That's what I want to say. Sometimes it's a life experience in you or your family that, you want to go into medicine as a result of that. Sometimes it's an inspiring doctor or somebody, a role model that you met that inspires you to become a doctor. And maybe you want to be the same specialty that doctor was. So I can't really say that one specialty is better than another. I know from my own personal experience and from the testimonies of a lot of other people that primary care is a very rewarding experience. Despite all of the hectic, chaotic, and disincentives that we face, the opportunity to be part of the patient's family or to be part of them, to enter into a relationship with them, it's just a great human experience. And, you learn so much about people and about life from listening to other people and how they've dealt with things over time. And you go through some of the crises in their life, some of the joys. The baby's born, somebody dies, somebody gets sick, there's an accident, there's cancer. You're with them through those different things. It's a very interesting experience. It's the best job in medicine, according to Dr. Beverly Wu. So in addition to the interpersonal relationships, I said that there's lots of opportunities. I think of primary care, like we say, primary care is the gateway into the healthcare system for patients. Well, I think primary care can be seen as the gateway for doctors into whatever career they want to go into, whether they really want to establish themselves in clinical medicine. And there are primary care doctors who are working in hospitals as hospitalists. The majority of them are working in ambulatory care. I think today it's pretty difficult to be able to do both effectively. And in our group, there's 2 doctors that will admit our patients and take care of them on the floor at Sutter Davis. And then if they need other things, usually get a specialty consult. But it's possible to be a hospitalist and be a family physician or an internal medicine doctor. There's also teaching, there's other careers, there's political advocacy, there's a lot of doctors that get involved with that. The other benefit is that, you get to rub shoulders with some interesting people. You're not in your own specialty silo. You're working with people at different levels of clinical skill and with different interests. And it really feels like you're broadening your experience all the time. And of course, it's the challenge. If you are up for a challenge, this cannot be a more challenging profession to get into, because right now we're going through a real transition. I was explaining that, I got into family medicine actually back in the 70s, that long ago. And those days, family medicine was really riding a high. It's had its peaks and valleys over the years. And Davis Medical School was actually formed to promote primary care. So I never really thought about another specialty in any serious way. I was always going to be family practice. But over the last 10 years or so, it's sort of fallen out of favor, and a lot of people are not getting into the profession. I think that may be changing now a little bit. There's certainly more stimulus and more incentives to go into primary care. And we'll see whether people take up that challenge. So during my research for this talk, I ran across this letter that was written by 4 medical students, senior medical students, who all chose primary care residencies. And they wrote this open letter to their colleagues. And this is you can find it on the internet. So don't take my word for it that it's an interesting challenge. They really are sold on the idea. Well, regardless of whether you're a primary care doctor or another specialty, regardless of the fact whether you're a doctor or not a doctor, or even if you're not even in healthcare, I think our society faces a challenge with how to improve the health of our country, our society. And it's really a responsibility that all of us share. I think that when you look at international comparisons, we see that our country has is sort of become sort of a joke, in terms of how other countries have handled these sorts of issues. So for me, the goal is to create a sophisticated, top-of-the-line primary care system in our country that has educated, engaged patients who are interested in their health, and that they work with a team of professionals who are working at the top of their skill level, and all of them are having a good time, a better experience for healthcare at a lower cost, and that we move our country back up on the scale of rankings for good health outcomes. So that's my talk. I appreciate your attention. I think we have a little time for questions if anybody would like, or comments if anybody wants to make a comment. Yes?
So you said that a big problem right now is this supply deficiency for primary care providers. How do you think the Affordable Care Act is going to, how will we compensate? Because we'll let that supply deficiency keep widening even more with this 32 million.
Yeah. Right. That Bureau of Labor Statistics didn't count for insured and uninsured, so there's probably going to be a little uptick on that. Well, I think that, like I said, there are some incentives built into the Affordable Care Act to promote primary care. And there are reimbursement schemes now that bundle payments so that specialists don't get the kind of fee-for-service for doing procedures that they have been. So there's going to be more equity in terms of compensation. So I don't think that, and I really think that there's going to be a greater appreciation for the value of primary care within the healthcare system. So, we didn't talk about that, but sometimes as you go through a residency in a university hospital, you feel like you're sort of like the second rate, oh, why, you're too smart to go into primary care. I think that will change, because really the system should be focused on a primary care anchor in the system. But the other answer to your question is that we need to employ multidisciplinary teams, that it isn't necessary to conceive of our healthcare system as being a doctor-patient the one-on-one relationship for all circumstances. Not that everybody doesn't have a doctor, but that every time you go to the office, you don't need to see the doctor. And if we can really provide those services in a satisfactory way and get good health outcomes, then I think that we need to recalculate what is the right ratio of primary care physicians to the population. Yes? It certainly varies by, the amount of debt that you have. If you're going to a private medical school, you're gonna, without financial assistance, you're gonna incur a lot more debt. If you are going to a public school, maybe, I don't know, I actually have lost track of what some of the tuitions are. I know that I think the average debt is certainly around 150,000. It's probably more like 200 or 300,000. So, that's a thing, a significant factor. Nevertheless, when you look at the population, what the average income is in the United States, you're still well in the 90th percentile. So you're doing well in society. It's only where you look to the people that are ahead of you that, you begin to feel that you're a little bit not taken, given the credit that you deserve. I can refer you to that article on the economic analysis because they actually looked at repayment of student loans and what it costs to own a home and a car and have a family, and they said that was financially viable. Only in the circumstances where there was a high level of indebtedness did people need to look at the National Health Service or the military or other options that give, debt forgiveness. But for the average debt level of graduating residents, the compensation right now is adequate, according to this analysis. Depends on what your goals are, it depends on what your family needs are, it depends upon what the level of debt is. So it's a personal sort of thing that you have to work out. But I think there's people who can give you specific advice if you wanted to find them. Yes, sir. What I said was that there are family practice doctors who function as hospitalists. And so in certain hospitals, they chose that, their interest is to go into hospitalist type medicine. And hospitals are actively hiring some family practice doctors and other primary care doctors to be hospitalists. I think that we're at a point in our healthcare right now where you're either a hospitalist or you're in ambulatory care. There's just too much technology and information in the hospitals now to be competent in taking care of patients in the hospital and still, maintain an active ambulatory care practice. But it's your choice. If that's what you want, I think that's available to you. All of us really, find what we like and narrow our practice pretty much in that way. If you like to do maternity care, you can deliver babies. If you like to do geriatric, if you like to do mental health, if you like to do, drug dependency, you can do anything that you want. I think all of those doors are available to you. Yes? Oh, I'll have to give it to you afterwards. I do have it here, though, on the computer. Yes? That's an estimate, yeah. Oh, I don't think it's a knowledge difference. I mean, I've run across some nurse practitioners who know a lot. It's a licensing issue at this point, where they don't have the state license to be able to practice medicine independently. So it's sort of the scope of practice situation So they practice under the practice, scope of practice of a licensed medical physician, medical doctor. Well, maybe I should clarify that. I don't mean to say that 50% of all patients can be seen by nurse practitioners. I should have said 50% of all patient visits can be managed by a nurse practitioner. I mean, we still want to have different providers available to them, and there is going to be a need for a physician to see that patient and to establish a relationship. I hope so, because that's really, what it's all about. But we have patients come back routinely for checking their cholesterol level, or checking their hemoglobin A1C if they're diabetic, or checking their blood pressure. And it's not necessary for the physician to see them every time. I mean, it's enjoyable sometimes, you do that, but it's not an efficient use of that person's skills. And oftentimes the patient winds up waiting several hours in the waiting room just to be able to have that 15-minute encounter. And that creates dissatisfaction, and it doesn't really change the outcome. So if we can find ways in which the outcomes can be kept the same or improved, and we can make it more convenient and a better experience, then we should do that. Yes, ma'am? Yeah. Yeah. Well, it's human behavior is complicated, and so you're not going to bat 1,000, with every patient. The secret really is to get engagement of the patient in their own health care. And a lot of times, we talk down to the patient, or we lecture them about what they should and shouldn't do. They feel like a child, and there's a sort of a passive resistance to that. So you need to find another way to do that. And maybe there is a behavioralist, or maybe there is a social worker or somebody else that can handle that problem. The other thing I say is, that the presenting complaint is often just the veil for what lies beneath it. And behaviors can sometimes be motivated or precipitated by psychosocial issues that we don't even know about. And so we're going to be batting our head against the wall if we're just talking about, diet and exercise, when they've got, domestic abuse, or they've got a drug problem or something else, or financial concerns, or you never know. It's amazing, when you unroof some of these things, what lies underneath it. So, those are my responses. We're not going to get 100%. We need to engage the patient in their own health care. And we need to have some empathy and try to uncover, so what is their motivation? What is their thinking on this? And how can we educate them or change them to that? Yes, ma'am. Well, the private practice of primary care is an endangered species. It's really not, it's not really practical anymore. Doctors used to, when we would finish residency, people were talking about going out, joining another doctor, or buying a practice even, or, starting their own practice in an area. People don't do that anymore, First of all, it's economically, the economics aren't there, because you need to have a front office staff, and you need to have a team really, to be able to manage that. And if you're just one doctor, you really can't do that. And you can't deliver quality care in that way. So you can join physician associations and share some of those, billing features and some of the other things that way. But a lot of people want the flexibility of their lifestyle, and so they'll want to work in a group, either a multi-specialty group or just a group that does primary care. And that gives them some better flexibility. So there's no reason, you can do it if you want to, and I think if you were to go out to, central Wyoming or Idaho or someplace, you probably would be the only doc within a 100-mile radius. So, you would do it in that situation, but, and it's really, lost its luster. People don't do that as much anymore. And I can understand the reasons why. Yes, ma'am?
You have that slide on diversity and how care is starting to get provided. Don't you think that would lead to a reduction of primary care providers if they?
You mean lower the demand for primary care?
Yes, if there's going to be easier convenience solutions so they can do everything online.
Well, they can handle some things, they're not going to be able to do everything. So I'm not sure, it's really sort of in its initial stages, infancy right now. I'm not sure even how, commercially viable these enterprises are going to be over time. And they certainly, raise issues about liability and, misdiagnosis and sometimes patient abuse. I mean, you get prescriptions for things that maybe, you haven't investigated what the allergies are or what their other medications are. And so, there's some issues there. I don't think it's going to really explode, but I think it's going to coexist probably for the foreseeable future. I mean, why not get a flu shot, at CVS or Walgreens? You just go in, your insurance is covered, you get it, and you're out. You don't have to make an appointment, you don't have to sit in the waiting room, all that kind of thing. So, for certain things like that, I think they're good. It remains to be seen how much further they will be able to go. Okay, I think we're drawing to a close. Oh, yes, sir, one more question.
For people who end up in primary care, what are the chances of them getting a job right after?
100%.
Yeah, that's.
It just depends where you want to work. Everybody's hiring. Oh, no. I'm not up to, because I'm not, but I think Kaiser is starting around 140, maybe even higher.
What about other than Kaiser?
Well, most, groups are going to be in that range. Yeah. I think the average primary care compensation was 137,000. That's a national average, and so there's going to be a lot of variation, but it's in that range. Whereas radiologists are making 300, so it's a big difference. But still 137, and sometimes you can work up. And there's going to be incentives now for quality and for pay for performance that will probably boost that some more. Well, there's going to be more residency slots available. So if you're going, some fields are pretty competitive, and you're not going to get them. I think in primary care, what I saw was U.S. seniors, 78 to 80% of them matched in one of the top 3 choices, and 95% overall. So most of them are going to get a good residency, the residency that they want. And I think there were some workshops that talked about how to, spiff up your resume and how to apply to get what you want. So I think when you get to that point, there's some really good information. Actually, if you look at the American Academy of Family Practice website or the American Academy of Pediatrics, there are booklets for residents because they're promoting, their specialties and how to prepare and what a residency's like and what you can expect. I couldn't find one for internal medicine, but I'm sure there probably is one. Okay, well, I think have we gone over time? We're not over time, but we can stop any time. Perfectly. That's what I like. Thank you very much.